So I think ischemia is totally groundbreaking. I mean, to pull off a trial of over 5,000 patients in 38 countries throughout the world of an invasive versus a conservative strategy is really a monumental moment, especially in patients with moderate to severe ischemia, those patients that we really thought there would be a benefit for intervention. And what we've seen, interestingly, is that in terms of hard endpoints, so myocardial infarction, cardiovascular death, all-cause mortality, and indeed the other endpoints that made up their primary endpoint, we saw no difference between the invasive arm and the conservative arm. And I think that's potentially practice changing. It really starts to make us think that these patients have very low event rates, and that potentially with optimum medical therapy and conservative therapy, some of these patients will be okay. So I think what was most interesting for me was the quality of life data, and obviously that marries up with ORBITA. In terms of the Seattle Angina Freedom from Angina score, what we saw was that the patients in the ischemia trial with an angina frequency of around 50, there was a number needed to treat of 3 in order to achieve freedom from angina in the invasive arm. Now for ORBITA, with the Seattle Angina Frequency score of around 60, we saw that the number needed to treat was 5. So, you know, some of that data marries up. Of course, ischemia was unblinded, and I do believe that maybe potentially some of that symptomatic benefit would have been placebo. Having said that, they took the follow-up all the way out to 36 months, and you would imagine that some of that placebo effect would attenuate over time. So I think there clearly are some patients out there who will do absolutely fine with optimal medical therapy. And I think the one thing we need to do now is marry the results of ischemia, courage, and ORBITA, and start to think about which patients we need to treat. The one thing I've learned is we don't need to rush patients to a cath lab, even when they have moderate to severe ischemia. These patients' risk is actually very low if we get them on the right medical therapy. And I think there probably is still a proportion of patients for whom we really need to think about intervention, and perhaps those are our young patients with proximal LAD disease. But then there's a big proportion of those patients that we treat at the moment who potentially we may not treat in the future with an invasive strategy and might think about medical therapy.